Okay, so I'm getting ready to extubate my patient. So my patient's doing well. She's going to come off of the ventilator. So I'm going to have my oxygen ready. So I've attached my oxygen and I have it turned on and here at the bedside. So I'll have that all ready. The second thing is I'm going to have my oral suction or my yank hour ready, and I have my syringe ready. So the first thing I'm going to do is I want to suction her one last time while her endotracheal tube's in. So I'm going to unlock my Ballard, holding my endotracheal tube, and I'm advancing the suction catheter until I feel resistance or see a cough reflex. I press my thumb depressor and I suction all the way back. Okay, then I want to suction the back of her throat. So I attach my yank hour and I suction the back of the throat. I want to clear out all the secretions before I take the tube out. Now I'm going to keep this hooked up so once I pull the tube out, I'm ready to suction. So the next thing I'm going to do is I'm going to just be sure that I do have a cuff leak. So I'm going to deflate my cuff. And I'm going to take my stethoscope and listen over the neck to make sure I hear a cuff leak. As long as I hear a cuff leak, then it's okay to extubate the patient. If I hear no cuff leak, I need to stop right there and reevaluate if the patient has any tracheal swelling. So I'm inflating it again. Okay, I'm going to untape my tube. Untaping my tube, a little trickier than, somebody did a great job taping this tube. Okay. Okay, so again, always keeping your holding onto your ET tube. Okay, got my tube. Now I'm going to deflate my cuff, completely deflating it, make sure it's flat. I'm going to have the patient take a deep breath and cough as I pull the tube out. Once I pull the tube out, I'm going to put the patient immediately on oxygen. And I may need to suction out anything that the patient's coughing up. Make sure you put her right on oxygen. Okay, around her very small ears. Okay, good. And now I'm going to listen to her breath sounds, and I'm going to listen over the neck for stridor. If she has stridor, I may give her racemic epinephrine in a small volume nebulizer. You can give it with a mouthpiece or with a mask, and again, that's only for stridor. Or if the patient might have some swelling, you could have always extubated her. Instead of a nasal cannula, we might have put her on a large volume nebulizer, and then we would have hooked it up to our tubing. We could have used the face tent, or we could have used an aerosol mask, and this would be hooked up. So this would replace the nasal cannula. So either way, you could have extubated her to a nasal cannula, or you could have extubated her to a large volume nebulizer. It kind of depends on the patient as well as the facility. If she hadn't been intubated very long, she could go to a nasal cannula. And after I have done assess the patient, I'm going to monitor her heart rate, her respiratory rate, and her oxygen saturation.